She's a 50-kilogram person. That's probably more than I needed. So drying medicine, and then I had Dr. Carlson gargle this viscous lidocaine. I asked her to gargle it very deeply in the back of the throat, and not for like the 30-second Listerine, but for about 2 minutes. Okay. And then the next thing I did was I blocked the glossopharyngeal nerve bilaterally with some viscous, with some hurricane spray. Okay. And what this is, the technique was originally described as a needle technique. And what you do, there's a membrane between the base of the tongue and the anterior tonsillar pillar where the lingual branch of the glossopharyngeal comes in. Okay. Originally described as a needle technique. I don't do that because the carotid is pretty close. And when you get unlucky, you get the carotid inject there. You don't want to do that. The other thing is, quite frankly, most patients, Ellen is uncommon, most patients, they got a small enough mouth, a big enough tongue. You try to get in there and see that membrane, you ain't going to see it. If I think I'm not going to do well with the gag reflex, I will sometimes simply use a tongue depressor with lidocaine ointment on it. And simply I have them use it as kind of a lollipop. And I get this lidocaine goo, literally this goo, sitting in the back of the pharynx for about 10-15 minutes, and it diffuses everywhere, and it'll often block that gag reflex. It'll often diffuse far enough to block the lingual branch of the glossopharyngeal. Let's test now. Thanks, Ellen. We're going to test Dr. Carlson's gag reflex, all right? We're going to find out. We're going to see if I'm winning or losing here, all right? So this is real TV, okay? It's like Geraldo. There may be nothing in the safe when we open it up.
You don't say it.
She still may have a gag. So we're good on the gag.
Right.
So that
You won.
so far so good. We're not done yet.
How long?
You get the mist going, and then they stick it right up against the tongue and the mucosa. Okay, you don't have mist anymore. You just get drips, and that doesn't work. You need that mist. Open your mouth real wide, stick your tongue out, and just breathe. Look at that. You're doing a fantastic job. Good.
All that.
Now, you hear Ellen coughing. Thank you. You hear Ellen coughing? That's good. Okay. You're doing a good job there. Deep breathing. Deep in and out. That's it. Deep breathing. There's no deep. Now, Ellen's only had 1 milligram of Versed so far. So just. Where's that? This is defog. Alcohol will work. It's got to be clean. It's got to be. So usually have an assistant keep the intubating airway in the midline, or the tongue pulled forward. Okay. You're doing a good job, Ellen. I'm looking at your glass. Alright, now the epiglottis is the first thing I look for. If I can't find the epiglottis, I'm lost, okay? So that's what I always seek, is the epiglottis. Once I find it, I know where I am. If I can't find the epiglottis, I almost am always lost. Because occasionally I am lost. And usually that's when I'm going oral and the airway is really weird. And when I get in that circumstance, I'll go nasal. Alright, so there's Dr. Carlson's epiglottis. So we now are oriented. Get down underneath that epiglottis. You can see her away. That's gorgeous. It's rare that you get this good a view. Dr. Carlson's being a superstar. You're welcome.
You can read chords.
Now, what's important now is to instruct the patient not to speak anymore. Yeah, okay. And at this point, I flex down just ever so slightly. It's like driving a truck here. It's a big stick. Now I see Dr. Carlson's carotid. And I I want to know where it is, but I don't want to touch it. Okay, now at this point, what I ask my helper to do is to take the scope. And I advance my intrathecal tube under vision. Usually I got my eyes here, so I still see what's going on. Advance here, and now I know because of my problems that usually with the glottis, what I'm going to do is I just usually go ahead and rotate it 90 degrees right from the start. I can feel some fullness in the back of the Deep breathing. Alright, now come back real slow, and what you see is, whoop, come back real slow. There's the trachea, there's the intrathecal tube, so you know how you got the placement. Thanks. So what I ask the patient to do now is do the wiggle the toes, squeeze the fingers. Now I think Dr. Carlson probably could tell a joke if I told you now. Now we got a little coughing during the day, but not much, okay? Okay, and Dr. Carlson, don't intubate.
If I ever see intubate, it's like a bad thing in your life.
Can you give a thumbs up to us? All right, you're done, my.
What is the taste of this local anesthetic you had? The good, bad?
Taste? Gross.
Okay.
So let's say it's an emergency, you only have time
What about the lollipop?
The lollipop, that was kind of weird because after you took the stick out, when it was still there, I was, you know, it almost feels like, you know, when you are eating something, you feel like you're gonna choke, and you get that little nervousness that you're gonna choke. That is what I was feeling like. Oh, because you're not used to having something back there, but
And what about the spray, the other spray?
that was okay.
Okay. Because a lot of people, I got caught them on the internet talking about how horrible experience sometimes. Is it that
I don't
bad
think
thing?
it was that bad.
Good.
Yeah.
Okay. So if you advise to have it, you'd have it at any time.
Yeah.
Thank you.
By Dr.